Those who don't know who I am, my name is Professor Helena Teed. I'm an endocrinologist and I'm as a clinician in women's health. I'm also an NHMRC Research Fellow, and the title of my research fellowship is Implementation for Impact. And well done to NHMRC for actually funding people who are doing implementation research to impact. It's been a long journey, but fantastic to see that can happen. So we're talking with you today about implementation science. I say we because there's a few of us here on behalf of the Women's Health Research Translation Network. So I'm going to be speaking first, but I'm joined by Dr. Bonnie Bramall. I'll turn the camera on to a moment, who is a fantastic PhD and postdoc with us doing implementation research. Bonnie?
Hi everyone, my name is Bonnie. As Helena said, I've recently completed my PhD here and moved into a postdoc, which closely links with implementation research. So I'll be sharing a bit of a case study today.
Thanks. And Leslie Arnott. Leslie, you're on mute, Leslie.
Thank you so much, Helena. Leslie Arnott, I'm the Consumer Partnerships Lead with the Women's Health Research Translation and Impact Network, and I enjoy engaging with consumers and linking researchers and consumers together and teaching them more about how we can work together effectively to improve health outcomes.
Thanks very much, Leslie. We're just going to bring Leslie in and out over the session today, and there'll be plenty of time for Q&A. So please do put your questions in there and we'll try and come back to them as much as we can. And Amy Armstrong is our Wharton coordinator. So thanks to Amy in the background. So we're going to share the screen now. So we'll just make sure that we've got the right program up here. And terrific. Put you into slideshow. Yes. Okay. So I'm going to talk a little bit about flipping the paradigm about leadership for collaboration and co-production, which is all about implementation. Now, the first thing, and I always start my talks for groups of women who are early in their career with the point that the reason you see all of those titles on that slide is purposeful. I used to just put Helena Teed, then I went and used my actual title, which was Professor Teed, without all the things behind my name. And then the point was made to me that actually, if you look at all of our male colleagues, they will always have their titles and their credibility up on their slides. They'll always be introduced because that frames the credibility and the sort of steps we've been through over our career to be able to have the authority to have some expertise to present to you. So don't be backwards in coming forwards. You should have your roles and your titles up when you're speaking. So that's just a first quick step lesson there. So I'm going to talk a little bit about implementation science. We can't do this justice. It's a bit like talking about clinical trials or discovery research. It's such a massive area, but we're going to give you a taster. Bonnie's going to give you a fantastic example, and I'll give you another more obscure example. But first, I'm going to give you a bit of background. So one of the problems is we're all researching in this environment. And I was very brave and showed this slide to a room full of vice chancellors from our top universities around the country not that long ago. And I challenged them that this is what their universities look like, that there are centres within schools, within faculties, within universities. So my university is the biggest in the country. It has 10 faculties, it has multiple schools, it has lots of centres. And it just looks like a mess in terms of silos. And when you're trying to work across those schools and faculties, there's all sorts of inbuilt competition that stops us from doing that. And then if you want to take that university and work with another partner outside, you're not just bridging that scaffold, you're actually walking a tightrope. And then if you want to try and work with different sectors all together, there's often no bridge and no tightrope, and you've got to try and make your own pathway. So the reality is we've worked very hard to set up a system that's beautifully siloed. And it doesn't matter how beautifully you paint them. The reality is it's hard to work outside what is the sort of confines we've had, where we as experts talk to ourselves about what we already know and don't necessarily take that broader perspective. So this is something I'd really like you to think about taking home with you after today. Everyone has their own understanding scope. You could look at the really devastating situation in Gaza at the moment, and there are so many different perspectives about what's happening there and why it happened, and everybody understands the problem from their own perspective. But the people in Gaza have a very different lived experience. And one of the problems, and that's an extreme example, but the reality is that as researchers, and if you're a clinician or medical researcher, even more so, we make the assumption that we know the nature of the problem, and we will, as investigators with our track record, write about the problem and come up with a solution, and then get very frustrated when it doesn't make a difference or get out into practice. And one of the reasons is we are deciding we know the problem without seeing it from everyone's understandoscope. We will never understand the problem as well as a collective group of people who are the key stakeholders that all need to come together around that problem. So the other problem we have is that many of us, as we get more skills and as we get beyond our early career, so I'd encourage you, if you're early and mid-career, to think about making your collaborations now, because you're less siloed and structured than you will be later in your career. But the better and more clever people get in terms of being more senior in a career, the further down their rabbit hole they are. And one of the great things about my current job, which is not my academic job, but my leadership role, is I get to walk around these fantastic universities and pull the rabbits out by their tail and actually make them look around and see the world a bit differently, and even work together with those that don't look like they do. This is a simplistic diagram, but it is uncommon to see this work well. The way, for example, many of our discovery scientists think of working with clinicians is to go and ask them for samples or ask them to be a CI on their grant the week before it goes in, not actually to come together about what the key clinical problems are. And rarely are our patients or community actually there at the table. Really important second lesson, the community in Australia is the funder and the beneficiary of research, and they're also the funder and the beneficiary of healthcare. And yet our engagement of consumers at the moment is quite token. So what are the problems we're trying to solve, and how are we going to work together to solve them, is probably the most important question you need to ask yourself on any research project you're working on. So with that sort of attitude we've had from research in the past, this is what the previous research paradigms have looked like. We're supposed to start over here with our honours students or our PhD students in a lab with a pipette, trying to come up with the basic pathways, really important, and new molecules which might turn into new drugs up here, might turn into clinical research, and might actually get into practice and make a difference. And these little T1, 2, 3, and 4 are the valleys of death that occur between them on that pathway. And one of the reasons that there's so much drop-off, up to 97% across this pathway, and it takes so long, is because we often don't start with what the biggest problems are. And we're not genuinely trying to solve a solution. What we're trying to do is come up with something really innovative. Now, perhaps the example of that was quite different, was the vaccine development. There was such a massive pull for that right here and right now, and innovation was just dramatic and rapid. But there was a genuine pull, and everyone got together about how they were going to do that in unprecedented ways. But for example, as a clinician, and I'm on my ward round, if I have a young homeless, drug-affected youth who has severe mental health disorders and also happens to have diabetes and is recurrently in hospital, there's no new drug that's going to solve that problem for me. That's going to be a much more complex, nuanced solution, so I can work with that person in their community with all the social determinants of disease. And it's going to require a different research paradigm to any drug that's going to be developed. So we need a much more strategic approach to research, and not necessarily just discovery. So we need discovery research and we need strategic research. And discovery research can still be strategic to make sure it's going to get through those pathways. But definitely research that starts and finishes with a problem and wants to solve a problem needs to be strategic. So this particular way of doing research has done some really good things, but is limited in its impact. And one of the reasons, which Bonnie will also refer to, is that supposedly you develop a great drug and it gets out there and it's published in New England Journal of Medicine, and bang, everyone's going to use it. It took us 17 years to get beta blockers into routine coronary care for patients post-heart attack, even though it was very clearly evidence-based, because it was nobody's job to take it from the randomized trial, which is an artificial situation with highly selected patients, actually into clinical practice. So this whole space of implementation research is how you take evidence into practice, and also how you define problems and solve them. So what we've got to do is move on from this concept to actually what are the biggest problems our community and our stakeholders and our funders have, and how are we going to work on them. And that is right from discovery research through clinical through to applied and public health. For example, I was involved in the setup of a reproductive health network around research. They all came together nationally to work together, which was terrific. And then we started to talk about what are the biggest problems to actually increase the potential share of the pie for reproductive health research. And one of the fantastic, very talented biologists in the room said, I don't really care what the biggest problems are. I'm really fascinated by this, and this is what I do, and I'm the world expert, and I want to keep doing it. And my response was, you can keep doing it, and if you get funding for it, that's terrific. But you're much more likely to get funding if you can make it relevant to actually the biggest problems our community is facing in fertility, which is age, rapidly escalating BMI, other key challenges directly relevant to reproductive biology, but with a particular population push. Then there needs to be a lot more focus on co-design and making sure we're checking back in with the community or the group that have the problem, and then coming up with something that is pulled into practice to solve the problem that doesn't have to be actively translated or nowhere near as much. So this concept of more of a circular approach is really where the rest of the world's been going for quite some time. So at the moment in research, I did in healthcare, we look very much like this. Everyone's got a target of better health outcomes or better impact, but the sort of we're beholden to individual project grants or fellowship grants, or the system isn't very strategic, and it's really hard often to collaborate together. That's created a bit of a burning platform around people getting somewhat disappointed or disillusioned with research, including those people who are doing it, but also those people who are trying to get benefit from it. Whereas clearly we need to collaborate, even though the system doesn't always incentivize us to do that. So we had a great review about 10 years ago of our health and medical research sector, led by Simon McKeon. They spoke to lots of clever people for nearly 2 years, and they came out with this inspiration, which is we all just need to work together. I must say they forgot the community, so we put them in there. But the bottom line is we should all be working together to actually come up with better health outcomes. And so they had a vision, which was better health together. They established research translation centres, and so there are many of them around the country which are increasingly getting traction. They wanted priority-driven strategic research, and they set up the Medical Research Future Fund, which gives out about $800 million worth of grants a year. That's a lot of new extra money in grants, but the focus here is not, I'm a great investigator with my great track record, give me money to do what I think is important. That primarily sits mostly with the NHMRC. The emphasis here is strategic research to address key clinical problems with stakeholders that are going to make a difference in driving impact. And so this is actually the MRFF success metrics. And I put this up because if you want funding from a group, let's see if I can get this to close, just bear with me. I've got something sitting, sorry, I'm trying to do it so it wasn't obscuring my, my slides. But the important thing here, sorry, just give me a second. Thank you. My trusty early career solved the problem for me. So the Medical Research Future Fund, if you want funding from the Medical Research Future Fund, you need to understand what their objectives are. And so the vision for that entire scheme is a health system fully informed by quality health and medical research. The aim is to transform health and medical research and innovation to improve lives, build the economy, and make the health system better. So anything you do is going to need to do that. And to do that, you're going to need to work towards partnership with others. And that framing can be anywhere along the research continuum, but it's really important to understand the focus's impact. The recent higher education review of our universities made the point that we are some of the least impactful researchers in the world. We do lots of research, especially our discovery research, but we commercialise a little. We collaborate inadequately, and our impact is just not sufficient. And so increasingly, we're going to be focused on making a difference and an outcome, which is where much of the rest of the world's been going for quite a long time. Things like, are you focusing on unmet need? Are you making sure more Australians have access to research? Are you looking at new health technologies and new innovations and new commercialisation and engaging with the community and improving health professionals' practice? And are you building capacity to do the sorts of things we're talking about today? So really important to think about as research increasingly becomes accountable, and in HMRC the same thing will happen. How are we all buying into improving outcomes? So I just made this slide just to point out, again, if you're looking at funding sources like the MRFF or even the NHMRC Centres for Research Excellence or partnership grants, they're all about how you're going to make an impact. And so make sure you read the relevant documents so you really start to think about it. So ultimately, the idea is we try to break down some of the silos, create environments with everyone empowered, including our community and consumers, not just at the end of our project, but right at the start when we're trying to work out what the problem is that we're all trying to solve together. And before I hand over to Bonnie, I'm just going to stop there and just ask Leslie for her insights about what we've just talked about.
Thanks, Helena. Fantastic presentation so far, as always. One of the things that I wanted to touch base on was something you mentioned earlier about research being relevant to the community. And I have to say, I'm probably doing a little bit of a plug here, but it's really important because it ties beautifully with this presentation today. And that is that on the 31st of October, between 2 and 3, we're now doing another webinar. And it's actually on something that you're talking about, which is linking in with local communities and how you can do that effectively. And so there's a beautiful case study, and Bonnie's going to present something to you today. There'll be another case study too on how a community really had a terrible health problem, and they partnered with researchers to help them solve that problem and how they can actually overcome what was going on in their community, and it was highly successful. So I cannot stress enough how important it is to work with communities. And the other thing too is that you know, with the NHMRC and the MRFF, they are just short of creating a massive mandate for all of their projects to have CCI as a component in them. And when I say cut short, they're just short of actually saying it, because they're now articulating that it's really, really important to involve the community in the research, because the insights from the community will help make it richer, but more importantly, it will help make your research projects relevant to improving health outcomes. So that's all I want to say.
Thanks, Leslie. And Bonnie has just pointed out that I skipped my acknowledgement of the country slide, which is appalling. So I'm going to hand over to Bonnie, who's going to do that in her slide. So there you go.
Okay. We looked quite calm, but we were having some technical difficulties, so that's why we did forget. All right. So first and foremost, I would like to acknowledge the traditional owners of the lands in which we are meeting on and presenting today, which for Helena, Leslie, Amy, and I is the Kulin Nations, and pay our respects to elders past, present, and emerging, and extend that respect to any Aboriginal or Torres Strait Islanders here today listening. So I have a little bit of a case study, which is about my PhD journey through to an early career research position here at EMCRs. So just a bit of background so it all makes sense. I'm sure a lot of people here will know this and understand this, but if not, we do know that reproductive aged women have a bit of a cycle of weight gain, and things like pregnancies and the postpartum period sort of exacerbate that weight gain and increase complications and weight retention, which increases risk to both themselves and their children, and then has epigenetic impacts in later life for their children as well. So it's a little bit of a vicious cycle. And my slide, touch it. Yep. So there's been quite a lot of interest in this topic in the last 20 odd years. So as you can see, in 2007, there was very sort of minimal interventions looking to optimize gestational weight gain. But since then, they have absolutely skyrocketed. So we certainly know about the issues, and there's lots of people looking to improve things and assist women and support them on their journey during these reproductive years, and help to optimize their weight gain during pregnancy. So this is just a little bit of background work done as well by another group, which we are linked into. So this is just looking at all the interventions that have been done to help women optimize their weight gain during pregnancy. And what it shows is that they are effective. So they reduce the incidence of gestational diabetes and hypertensive disorders. They also reduce NICU admissions, so neonatal concerns. They help to reduce preterm delivery and also cesarean sections. So it's quite evident that lifestyle interventions are protective against excessive gestational weight gain and the associated complications. So here is the famous picture that we all love using. So we have all this evidence and we know the problem, but the key gap is that implementation phase where we sort of reach women. The issue with all those studies that we just looked at is that they all have sort of minimal reach. So that's where this body of work from Helena, Cherise Harrison, and numerous other researchers and clinicians at Monash comes into play. So since about 2005, there's been lots of interventions and lots of research looking to support women and find out the best way to help them optimize their weight gain, not only during pregnancy, but through that whole reproductive life phase. So there's been RCTs in sort of regional and urban communities, in sort of antenatal pregnancy clinics, and this whole lot of research has shown that we can effectively reduce weight gain in quite a simple way. And then at that end point there, at the 2019 mark, was when I came into play with my PhD. So what we have here is the sort of cycle of the project that I came in on. So we had teamed up with Medibank Private, which I will sort of speak to a bit more later in the piece. But what that enabled us to do was have sort of a key stakeholder and a bit of an implementation partner, so to speak, and enabled us to utilize their skills and expertise and their reach, and also their sort of data and all those amazing things that a commercially driven a business has. And we used that to meet their needs, which was to reduce the complications of women during pregnancy, but also then to support women and reach more women. So this is just a bit of a cycle of how we went about everything. Stakeholder engagement was very important. We not only utilised engagement with Medibank, we had co-design with women who would receive it. We spoke to people at the hospital. Helena was very well informed by, sort of the political realm and how we wanted to reduce things from a public health lens. We pulled all that evidence together with guidelines, synthesis, and all the knowledge that we had. And then we came up with a bit of a resource package, continued to co-develop it and co-design it with women. The implementation partner weren't involved in the co-design. I think that's a very important element. We kept those sort of entities separate. So we were developing the program as the experts in this field, and they just facilitated our sort of recruitment and helped us reach more women and have a bigger impact. And then we're using that knowledge to continually translate it, scale it up, and then looking at the health economics of it and everything like that. So it did take me quite a long time to get my head around implementation science. And if I'm honest, it probably wasn't until the end of my PhD that I truly grasped the concept. So I thought that this sort of simple summary of it might be helpful for those of you who are just sort of coming across the idea and thinking about how it can be applied to your work. So implementation science enables us to turn good ideas like an effective lifestyle intervention into real-world actions. It helps us take what we know works and make sure people actually use it. It's going from it works in research to let's do it in practice. And this is a perfect sort of summary of how we used implementation science in the context of my PhD project. So implementation research seeks to understand and work within real world conditions rather than trying to control for these conditions or to remove their influence as causal effects. So what we did really well in the Optimal Me project, which was the collaboration with Medibank, was instead of trying to take an intervention that was quite complex for women, hard for researchers to deliver, and didn't so much fit with their lifestyle at scale, we sort of looked to women and what they could achieve in their life. So it implies working with populations that will be affected by an intervention. So we went to the women and assessed what would help them rather than selecting beneficiaries who may not represent the target population of an intervention. So the aim of our program was to generate key implementation learnings. So we started to move away from outcomes like weight, because it already been shown through all the plethora of RCTs that what we were doing and trying to do could be effective. And when you are sort of tied into a research setting and the confines of a research program, obviously that does start to impact the way you deliver the program, the reach of the program, and also impacts sort of the way it's perceived by those who are receiving it, so the women. So what we did was we sort of took away that research element and we focused on the implementation learnings and the scale of the program in a context of how it was effective. So the primary outcomes of the program are the penetration, reach, and the feasibility. And then we've looked at the acceptability, adoption, and fidelity. And then secondary to that, we're looking at individual health outcomes, including knowledge and risk perception, health literacy, self-management, and health behaviours. So less sort of measurement and those really sort of restrictive things that can make research really complex, and taking a more practical approach to the program. We used some frameworks, which we're not going to talk too much to today because you can do a whole master's on those. I do have a few slides on them, but I will skip through them. There's a plethora of frameworks that you can use. It does become quite overwhelming when you do start looking at all the frameworks. So that's one part of implementation science that can be very confusing. But for us, we use the CEPA and the RE-AIM. And using a combination of two can be great, but don't try and use too many. So this is the CEPA for our program. Well, this is the CEPA, but in context of our program, we use the outer setting, the inner setting, and then the individual setting as well, which is on this next slide here. So the core was the program that we'd been delivering for many years. Well, not me, Helena and Cherise had been delivering for many years. So it was theory-driven, low intensity. It was delivered by health coaching with ongoing support. But the sort of limitations of that was it required the research team to go out to the communities, deliver the intervention in small groups, go back out to Mildura or wherever it was being delivered with a scale and find some poor lady on the street, weigh her, make her collect a survey, fill in a survey. So those limitations we started to think about sort of adapting and remodeling. The outer setting is all the evidence, the guidelines, and we started to think, is pregnancy too late to be intervening to prevent gestational weight gain? So that was another part of the adaptation, which was to move it into preconception. The inner context was Medibank, so their national membership base and their policies. But what this enabled us to do was reach women during preconception, so in that formative phase before they've fallen pregnant. And Medibank had that unique insight as to women's pregnancy intentions. So it enabled us to reach those women in this sort of planning stage and hopefully optimize their behavior and lifestyle prior to falling pregnant. The individuals was sort of the privacy red tape, which was a challenging thing to get past. and sort of operations versus content experience. So we co-developed the recruitment process with Medibank, but then the whole intervention was delivered by Monash and the experts in this field. And then we have a process evaluation with both stakeholders and consumers. So I've spoken to this a little bit. This sort of just shows a bit of the intervention. So it was a very user-centered design. While, you know, I do still sit at Monash and did do a PhD, so we were interested in collecting data. We ensured that that data was collected in ways that didn't burden women, and we sort of linked it to elements of the program. So a health screening enabled them to learn about things that they needed to potentially improve. So it really took away that sort of research feeling and made it feel like something that benefited the women, which it was meant to do as well. But we always designed it with scale in mind. So it became a digital intervention, which enabled us to reach women across all of Australia. It gave us that unique insight into a very personal decision in women's lives, which they probably don't necessarily want to be discussing, you know, in a group setting potentially. So we were in the privacy of their own home. We delivered the health coaching via phone and video, so that was private as well. And we met women at times that suited them. So we did a feasibility and scale analysis, as I say, moving away from that sort of outcome analysis. And then we have used the RE-AIM framework to evaluate the Optimal Me program. So this is the sort of primary aims. So it was underpinned by RE-AIM in both quantitative and qualitative analysis. We used all the sort of data from the platform, as well as some semi-structured interviews, and we collected data all throughout to understand sort of how it was impacting women at different stages of the intervention. So the primary outcome is the implementation feasibility. So we wanted to look at it, how it could be feasible for future scale up. Was it acceptable within this inner setting? We looked at our reach, which was obviously quite linked to Medibank at this stage, but there was quite a lot of interest in the program. And then we looked at how we delivered it in terms of fidelity. Did we do it as we intended to in terms of the design? Were there any variations? And we had a pretty close look at facilitators and barriers for ourselves as the researchers, the women involved, and then the implementation partner as well, so that we could understand how we could take this to other places, as well as other sort of bupa and hospitals, other people other than Medibank, and understand how well we did that. And then the adoption, so factors influencing the implementation within all those settings, the women, Medibank, our setting, our health coaches, etc. And then the cost effectiveness of the program, because that's a big one for the overall feasibility and the ongoing scale of the intervention. I won't speak too much to this, but this is our sort of secondary evaluation. So this is more about participation. Once again, acceptability. So was a digital intervention acceptable? Just because we thought it was, it doesn't mean that it was going to work. We looked at that in quite a lot of depth with interviews, as well as looking at the digital backend data. And then was it effective? So looking at those baseline health behaviors, self-reported weight. So we did still record weight, but it just wasn't as sort of strictly monitored as would be in an RCT sort of setting. And then we looked at their health literacy, their self-efficacy, and their self-reported outcomes, because at the end of the day, we're doing this for the women. So if they believe that they've improved their diet and lifestyle, who are we to sort of tell them that they haven't? And then ultimately at the end, we have the amazing opportunity to look at all of Medibank's data from women's sort of hospital admissions through birth and pregnancy, and understand how we did impact that sort of overall experience during pregnancy. And now as a postdoc, I am part of a very exciting opportunity to scale this digital intervention. A lot of the work in my PhD has been sort of unique, systematic searches in forums and places where women ultimately are interacting during pregnancy, where we don't generally go to them for a research setting. So we've done a systematic evaluation of apps with gestational weight tracking, because ultimately that is what women are using at the moment. So understanding what they're using, what they're absorbing and reading is really important to us. And then we can use our digital intervention to meet the needs that they expect and want to be met. So we're constantly looking to be informed by consumer insights and co-designing our programs. And once again, we are aimed at reach and feasible growth, and always interested in how we can scale things. So once again, we're looking for collaboration opportunities for enhanced scaling and capacity. And so if someone wants a very good example of a implementation program protocol, scan the QR code on the screen right now. We can also share it with you later, but it's a very great program protocol with an implementation lens. And now back to Helena.
So thanks, Bonnie. So you can see she's passionate about, not too many people come out of their PhD and love what they ended up doing. So I'm just going to tell you so Bonnie's did some terrific work. That was one of the implementation programs around this. But really important to say, we had 117 randomized control trials, including many of ours. We had clear evidence of efficacy. We had this particular implementation program, which took it into preconception, but we also had a lot of others where we actually embedded it into routine care with hundreds of women and showed we could go from a 10% recruitment in a randomized control trial up to 95% of women getting the program, where it was part of routine care and that it was still effective. We have some challenges often with just sustaining those models, but they're actually quite effective. So I then spent a lot of time meeting with government, who ultimately need to be the funders of these programs, to say, what would this program and the evidence have to look like for you to implement it? And I can tell you that a randomized control trial was the first step. And it was so far from what they needed that it was never going to happen. So one of the critical things was to meet with Treasury, who were the ones who fund this, and say, what do you need to implement? And they basically said, we need health economics analysis and a budget impact analysis and a partridge in a pear tree. So we went on a journey to make sure everyone who needed things had it. So the first thing we did was look at all the different types of interventions and published on these to say who delivers it, where they deliver it, what they deliver, so people would know what it needed to look like. And then this framework pipe was about how we reach the most number of people. And that was where all the evidence fell down, because all the randomized control trials just used very select populations, as Bonnie said, and did lots of endpoint collection, but actually were highly selected populations. So that was the gap that we sought to address. We then did a lot of work on that consolidated framework, what policy settings, what organisations, what individuals, as well as what the evidence-based intervention was coming in. And then our, fortunately, very beautiful financial health economics analysis shows major health benefits and major cost savings. And we're now at the point of implementing. We have multiple MRFF grants, and we're working with the UK and the US to implement as well. But none of this would have happened from the RCTs. And so I think this is a really good example of the type of research you have to do right back from the start. Now, some of you may think, well, hang on a minute, I'm not doing, that very applied public health research. It doesn't matter where you apply this implementation lens to. We've used the same implementation approaches. What is this? What are the stakeholders? How do we get them in the same room? How do we understand the problem from everyone's perspective? How do we solve it together in real world practical ways? There's a paper coming out in the MJA shortly, which I've headed up, which is called implementability. And it means no matter where you're doing your research, even early phase clinical trials, you need to think about how to make your project implementable and useful. Don't do a trial with 16 dietitian visits in pregnancy. No one's ever going to implement it. Always think about what you're going to do that's actually going to be feasible to implement, not just the science. And so that becomes really important to consider. And then there have been other implementation studies where we have actually put in very complex IT systems and software systems into hospitals to actually help them do natural language processing, and really high-tech image analysis. So even back there, the actual problem is not the technology, it's getting everybody together to implement it. And we've managed to do that at scale. So these sorts of ways of thinking and skills and approaches are really important. So I'm going to give you one more obscure example, and then I'm going to hand over to discussion, which is another completely different example. The great thing about these types of approaches is you can ask any question, albeit anything but a very early discovery research problem. And you can say, I have a problem, I need to fix it, how do we get everyone together? And so, for example, one of the things I did, and understand I did not have expertise in this area to start with, I brought the skills in implementation, but not the content area, was the CEO of my health service that asked me would I be involved in addressing the issue around culture and sexual harassment in my health service, which is the biggest health service in the country. Now, that's not normally my skill set, but actually the principles of change management and implementation are equally effective here as they are anywhere else. So we decided to use those frameworks. Again, I'm not going to go into them here, but this is a consolidated framework. What are the characteristics that work? What are the policy settings? What about the organisation that's implementing change? What about the people I need to get on board? And how am I going to do it? This is a process you might use, and there are many of them. And then how am I going to evaluate them? And Bonnie's given you the reach, effectiveness, adoption, implementation, and maintenance. If you have an interest in these programs, there are many, both online and also face-to-face training programs you can do. In fact, our team offer one that really take you through the frameworks. But that's not the point of this. For example, we have this problem here in healthcare delivery. Academia is the same. Most of our frontline workers are women. Most of our tertiary educated people in this country are women. And actually, when you get to the people who are really leading this, they're actually primarily all men. So how do we reverse this? Everyone spends a great deal of effort making the case for the problem. And there's almost, you can look at that almost anywhere. If it's about managing diabetes or fixing gender inequity or fixing sexism or fixing racism, or even addressing civil unrest, there's a bucket of literature about the problem. Then there's a bit of literature about, and there's many examples here, racism, sexism, obesity, many situations where we think the problem is an individual problem, whereas it's actually not. There's really good evidence that most of the time these things happen in the context of a rotten system. That includes when war breaks out with civil unrest. It includes obesity. A couple of decades ago, obesity was uncommon. It is incredibly common now. That's not a problem of an individual, that's a problem of a system. But most of the research doesn't focus on implementation and fixing the system. So this is one of my biggest capacity challenges. These are my children. And when I was trying to promote and advance my career, I was really torn between spending time at my family and spending time at work. And one of the reasons is not because I didn't have enough time to be a mum or enough time at work, but because the system did not support me to be able to do both well. And so it feels a bit like pulling a rock up a steep hill. So we've applied that implementation system science to this problem. And I have to say, we started not very long ago. We now have 2 partnership grants, $6 billion in funding, and 23 partners, and have got really big, large-scale change because we use those really effective change management programs. And so when you're starting anything like this, you need a vision, which means everyone needs to come together. You need the right skills, which are not always in your own group. You need to be able to make sure that it's important and there are incentives and you've got funding, and you need an action plan. Almost never does everybody line all these up. And this is part of implementation science, which is all about making a difference around a problem. So I won't spend much more time on this except to say these are the stakeholders we had in this project. We needed health services, we needed colleges, we needed member organisations, government, and also academia. And we brought them all together to define the problems. These are some of our partners. As I said, we're now up to 23, and we co-produced the whole program and focused on the system. And I won't go through too much except to say we had protocols, evidence synthesis, qualitative interviews, we had Delphi processes, massive surveys, and then implementation development. And we found out what actually works. Again, I'm not going to focus too much on this, but the yellow box was the most important. If the head of the organisation didn't think this was important, it was never going to change. And the people at the bottom making the loudest noise about the problem were never going to make a difference without that leadership commitment. So our job became about making this the problem of the CEOs. And so I'll skip through that, but just to highlight that we've been through a whole range of evidence synthesis and knowledge generation. And now we're taking all of that evidence into practice and actually implementing and scaling that across our partners. So this is a different example of how you use implementation compared to Bonnie's, which is taking randomized controlled trials into practice. This was identifying a problem and solving it. And I just want to acknowledge some of the people who are involved here, including Dr. Mariam Musa, who did her PhD here, but also highlight this ended up published in Lancet series, in New England and in JAMA, the JAMA network series. So it actually had a big impact because it was around the fact that it was an important problem. So I'm going to stop sharing there. I'm going to ask Leslie for reflections, and then we'll go to questions.
Thanks, Helena. One of the things that I'm quite delighted to hear is that I am so pleased that, RCTs are not the only answer. And I think that's so important for us to know in our field of work. We cannot always rely on it. And I always say from time to time, there's more ways to skin a cat. And I think you found another one. So my apologies to all those cat lovers out there. It's just a metaphor. I do have a question for Bonnie. I was interested to see you teaming up with a private health insurer, and we know that there are a lot of people out there who can't afford private insurance. But I'm hoping that your answer will be that it was a start and it catapulted a response. So therefore, in your upskilling, we can actually reach all of those other women who, number one, can't afford private health insurance, but also who are non-English speaking, who come from various different cultures and that type of thing. I wondered if you could talk to me about that.
Yes, the ultimate limitation of my PhD.
Sorry.
Yes, so it was a stepping stone, and as I sort of did mention, but probably didn't highlight well enough, what it did enable us to do was to reach women who had sort of signaled that they were thinking about pregnancy. It's such a personal time, and not everybody is sort of walking around with a label on their head. So it was a starting point. How we reach women in the general population, I haven't quite worked out yet. I think I might spend the rest of my career doing that. But what we did learn from it was that we could effectively, reach women and work with women during that time. And now in the postdoc, unfortunately, we are sort of flicking back to intervening during pregnancy, but with all those amazing insights from women during the preconception phase. And then hopefully looking to reach women planning, and maybe even into conception is an opportunity. It's something that we are always thinking about. But if anyone has any great ideas, please do let us know.
Happy to work with you.
Really important point. It's interesting because we're really into equity and access, so it was against our grain. But can I just say, it is almost impossible to reach people planning their first pregnancy because they're just not out there. But what Bonnie was getting at was, when you're thinking about pregnancy and you're privately insured, which is 51% of Australian women going into pregnancy, so it's not just the elite, you have to upgrade your insurance. So you're letting someone know that you're going. So that's the only reason we went there, because we knew they were planning. And as Bonnie said, now our big strategy is to go for women who've just had a child, majority of whom will seek another one. So we know we can capture them there. No one anywhere in the world has captured them otherwise before their first pregnancy.
It's just brilliant. It's a wonderful starting place to just enable that to flourish. So well done, Bonnie.
And I think just unfortunately their health wasn't overly great either. So it just does show that, irrespective of women's education level and their SES, we do need to be doing things to reach everyone rather than just focusing on those minority groups as well. I think that was a big finding from the work.
I think, though, when we are approaching government and treasury and all those types of things, that if these outcomes even were achieved through, a private sector, it still means that it will work everywhere else, which means then that we have a greater impetus to actually implement it right through the care journey as well. So it's just fabulous. Great work.
Right. And I'm just looking, there's some comments about your webinar, Leslie, in the chat too.
Oh.
So there's a link there, so I'd encourage people to sign up. So Carol had a question about RCTs are not the be all and end all. And believe me, I totally agree. But they seem to be the main thing NHMRC and MRFF like to fund. So can I just reassure you, I probably shouldn't say this in public, but the vast majority of grants that we have submitted to MRFF have been funded. Our limitation is the amount of time we spend with our partners actually working up the grant. So we bring everyone to the table around the problem. None of them have been an RCT. They've all been through implementation trials. Some of them, one of them was an implementation effectiveness trial, but they're step wedge, they're embedding into routine health services. So they're very much the implementation and scale up. They're not randomized controlled trial with process evaluation. So you're right, to some extent, Bonnie's was that, but the difference with Bonnie's is it was really liberal inclusion criteria, very limited exclusion criteria, and they were only randomized to 2 forms of effective intervention. So they're all getting the intervention. And the other interesting thing is that the endpoint was not clinical outcomes; it was actually the reach and the so that the endpoints were actually the process points. But no, we've moved much more into embedding in clinical services and really moving away from that sort of the scale up. And to be honest, there are now a whole series of scale up research frameworks, which are more about once they're in there, how do you evaluate and maintain them? So it's a whole new field of evolution. Now there's another one, great project. Thanks, Bonnie. That'll be yours. It'll be appreciated if you can tell us a bit more about health coaching and ongoing support. Do you want to just perhaps allude to that?
Yes. So in the optimal me intervention, we did health coaching via telephone and video, and it was all based on the women's personal objectives and quite sort of loosely catered towards their lifestyle behaviours that they wanted to improve. So rather than sort of going to women and telling them what they should do, we did health coaching in a much more general sort of way that worked within women's lifestyle and health. And we also do the same sort of coaching in a pregnancy clinic at Monash Health as well, and it does work quite well. And then we support that. Obviously the digital intervention had a whole lot of behaviour change tools, but we also support that with sort of SMS messages. But one of the big findings from the PhD was that women always want more, so we constantly looking at how we can improve the digital intervention to make it more personalised and, you know, more constant reminders and whatnot. So taking away a little bit of the onus of the health coach with embedded sort of personalisation into the program itself. Hopefully that answered the question effectively.
And there's another one here about super webinar session. Great, thank you. The compliment to the Treasurer's move around holistic wellbeing. You're totally right. This is actually about thinking about what matters to the community who fund our research and fund our healthcare, and what the most important impactful endpoints are. And you'll find, for example, a lot of the work that our group does is a lot of it's about equity and about access and about underserved populations, whether it's geographical, cultural and linguistically diverse populations. And so it's really, it really is about thinking about the much broader context. We find this sort of research where the outcome is impact is much more rewarding than I remember I said to Bonnie not long ago, and this is the only second paper I've ever had in New England Journal of Medicine, and it was published on the same day that one of my PhD students got a first author paper on grounded theory from qualitative research in the JAMA series journals. And I was much more excited about that paper, in fact, than I was about the New England, because the New England was a classic randomized controlled trial in a highly select population with one core outcome, and, you know, a ton of literature, which is interesting, that we collected. But in terms of how we're going to use and implement it, everyone's still struggling with that. So I think it's not to detract from the critical need for randomized trials. But what we've seen is people start with drug discovery, which is vital, blue sky. They move into clinical trials, phase 1, 2, 3, and then they get to 4, and they keep doing the same thing. That 117 randomized trials about effectiveness in pregnancy, as all around the world, they all work, you know, and so we need to stop doing more and more randomized control trials because we think that's the end of the road. What we need to do is think about what the research program is. What are the problems moving that into practice? Who are our stakeholders? How do we then design trials that are seen to be rigorous enough with a process that gets you to your endpoint? And just to encourage people, when you're writing these things for funding bodies, we don't write a protocol. I mean, I've got large-scale RCTs, that's fine, but they're not my passion anymore. But our protocols are not written in a standard RCT way for our funders, both NHMRC, MRFF, Horizons, NIHR funding. We write them around work packages, engaging and identifying the stakeholders, problem ideation, evidence synthesis, bringing in a lot of co-design aspects. So it's more around the process we will use to implement into practice rather than a sort of standard protocol or recipe for a particular outcome. Because the problem with implementation science is you don't know what the outcome's going to be when you start the journey. You just have to convince people that you're applying to that you're going to have robust enough measures on your journey to make a difference. And I can tell you, we always do that within the time of the grant because of the nature of the intervention. So on that, I can't see any other additional questions. Leslie, final word to you.
My final word is I just hope that our funders embrace more and more this approach, because I love the idea that things can actually get on the floor quicker than 17 years. I'd like them to get on the floor in 17 months.
Wouldn't we all? And in fact, Leslie co-led a process of consumers across the country around what they wanted from research. And one of the key findings from memory, Leslie, there were a number of things. One was innovation, but the other one was getting evidence that's there out into practice to make a difference.
Yeah, the two major ones, right? But I mean, innovation was the third. The first one was, I love the fact that equity was the one which was, all women need to be able to access whatever it is that they need to access. And the other one was, can we just use the evidence that's already there? It's there. We don't need to have any more RCTs. Let's just get it into practice. Yeah, that's exactly right.
Great. And for those of you who are interested in more about implementation science, there's a couple of centres. There's our centres who run training programs and have resources. There's a centre, the Macquarie Innovation Centre, and there's also a Centre for Research Excellence and Implementation, which is also in Sydney, which is focused specifically on public health and lifestyle intervention. So do look out and see. That's great. And what was that about? Someone, thanks very much. Someone just said, my female, great. Yes, please do. There's a lot of capacity building in this network. We got this grant to build capacity and to broaden horizons and collaboration. So please do let your ECRs know. All of the webinars, and there's many of them, are all available on the Wharton, the Women's Health Research Translation Network website. So please do direct your teams to them. They're on capacity building, mentoring, leadership development, grant writing, project management, you name it. So good luck.
And consumer engagement.
Oh, how could I forget? Actually, they start and finish with consumer engagement, Leslie, and Indigenous and working with Indigenous populations.
Yeah.
Thanks, everyone.
Thanks.
Thanks.
Bye.